Welcome to the Parson series, and this is part 2 of chapter number 6. So if you remember, last time we discussed about the beautiful concepts of retinoscopy. Today we will be continuing with the cycloplegics in refraction. As you know, we always use the mydriatics and cycloplegics to be getting more accuracy while doing the refraction. So let's see the minor details in it. Cycloplegics. Now what do you mean by cycloplegics? Cycloplegics means which are paralyzing the ciliary muscle and they are dilating the pupil. So basically when they are talking about cycloplegics, they are talking about the mydriatics and cycloplegics. So I think they should have used this word better, mydriatics and cycloplegics, but nevertheless they have said only cycloplegics. But don't get confused, when they are talking about the refraction, we are talking about both mydriatics and cycloplegics. Now let me remind you what was mydriatic. Mydriatic means which will dilate the pupil, and cycloplegia. Cyclo we are using for the ciliary muscle. This is your ciliary muscle, and plegia we know is the paralysis or the palsy. So basic aim when we are using the cycloplegic is that we are dilating the pupil. Why I want to dilate this pupil? In order to nullify the effect of accommodation. And when I want to paralyze the ciliary muscle, I want to nullify the effect of the ciliary muscle, because we have to inhibit the ciliary tone. Now, if you remember ciliary tone is able to inhibit about 1 diopter of hypermetropia. So, when you want to get the total amount of refractive error, we have to nullify the effect of ciliary tone also, and we have to nullify the effect of accommodation. If you dilate the pupil, the patient's accommodative effort is gone. Alright. Now, because of this strong accommodative reserve, the younger people will be given the stronger cycloplegics. Now we have got different range of cycloplegics, starting from the most strong, then we have got the mediocre variety, and then we have got the milder variety. So in cases of young people, we are using the stronger ones because they have got what you call as the stronger accommodative reserve. So those who have a stronger accommodative effort, we have to give a stronger cycloplegic in order to abolish it. So less than 16 years, we are using the atropine, and that is why if you remember, we always do this question that what is the strongest mydriatic and cycloplegic? That will be atropine. Atropine should be used, and with the most hypermetropes older than 16 years, we have to use the lesser one, which are lesser powerful. Okay, there is no need for cycloplegics in the adults. Now if you remember, mostly in your age group also, you people are not going for mydriasis and the cycloplegia for the refraction, and you are going for the computerized eye testing. So that is actually the autorefractometer, where you are not dilating the pupil. Why? Because we do not have that strong accommodative reserve, so we can go for the refraction directly also. So in adults, the accompanying pupillary dilatation can be done, especially for the beginners, because we have a problem in seeing the reflex if you are doing the retinoscopy in the beginning, but otherwise it's not much required, and you can go directly also. This should be used, however, if there is a suspicion that the accommodation is abnormally active. But some people who have got accommodative spasm, abnormally active accommodation, in that case you should go for the mydriatics. If the objective findings by retinoscopy do not agree with the patient's subjective requirements, then again also go for the mydriasis. Now a cycloplegic and mydriatic. See, now they have come up with the right word, mydriatic and a cycloplegic. They may also be indicated for the ophthalmoscopic purposes to view the macula and the periphery of the fundus. So when it comes to the uses of mydriatics and cycloplegics, doing the retinoscopy is one of them and the most important of them. But of course, we have got other uses also, like we are viewing the macula and when you are seeing the periphery of the fundus. So most of the time when you require the fundus view, you have to dilate the pupil. For that purpose also, we are using mydriatics and cycloplegics. It is to be remembered, however, that the refraction in the cycloplegia is not final. Now this is again very, very important. Don't consider that refraction to be the final refraction. Why? Because when you are doing such retinoscopic findings, the findings that you are getting is not with the normal shape of the lens. So obviously you have to wait for a certain period till the time the shape of the lens comes to its original position, and only then the findings that you get are your final one. So the important thing is, if they ask you why you require the PMT, do you know PMT? It is a post-mydriatic test. Mostly we are doing it after 3 days. So you require it because you require the shape of lens to be normal. Okay. Now, moreover, with the mydriatic, the refraction of the peripheral part of the lens is often estimated and not the central one. Another important reason why I require the PMT is that while you are doing the refraction with the pupil dilated, you are actually taking into account the periphery of the lens, which is not often required. We require the central part. But with the pupil dilated, you are getting the refraction of the periphery too. So you have to wait for it so that the pupil is coming back to its normal shape. You are considering the center of the lens, and also the shape of the lens is normal. So this is called as a post-mydriatic test, or we can also call it as a post-cycloplegic test, is therefore very, very advisable. When the refraction is estimated under cycloplegia, a correction has to be made to compensate for the normal tone of the ciliary muscle. Then another important thing is that you also have to consider the factors like what kind of cycloplegic you are using, because there is some tone of the ciliary muscle, so that factor has to be reduced. So you have to remember the value. 1 diopter is reduced for the atropine, and 0.5 diopter we are using for the other one. Now, usually you have got the specific values like 1 diopter for one, then 0.75 and 0.5, but they have actually given you the general values. So you can remember it like this: 1 diopter for the atropine, this is very, very important, and for all the others we can use 0.5 diopters. And I think this is good also, because when you are doing the calculations, this 1 diopter and 0.5 diopter will be advisable and will be very helpful for the easy calculations. All right. And you know that the biology people are very good at maths. So if you are doing this calculation with 0.75, there are more chances that we stuck up. Okay. So a very, very important thing that we always do in the classes, atropine is the most powerful cycloplegic for the young children. We are using it as 1% ointment. Now, if you remember, many of you asked me in the classes that why we are using the ointment and not the drops. Like in adults, we are using the drops. So see, they have given you beautifully that if you are giving it as a drop, systemic toxicity can occur due to the absorption of atropine from the conjunctival and the nasal mucosa. So now atropine is good at mydriasis and cycloplegia. It is the strongest mydriatic. We are using as 1% ointment, but the side by side, it is also causing the systemic toxicity. And see, the route of absorption is from the conjunctival and the nasal mucosa. The ointment, now see the frequency, you have to instill it 2 to 3 times a day. So I will say that remember it as 3 times. So you have to use it 3 times a day, and before you are using for 3 days. So you have to use it 3 times in a day and 3 days before, because if you look at the onset, how much time it is taking for the onset, it is about 3 days for the onset. So mostly we are giving 3 days before. So if I have getting the refraction done on Monday, then what I'll do, I will advise them to use it from Friday. So they'll use it Friday, they'll use it Saturday, they will use it Sunday, and then they can come for the refraction on Monday. Now you will say that we have discussed this, that we will be using HS. This is what I told you, because we are giving in the ointment form. So I don't think that children are comfortable using ointment 3 times a day, and it is such a strong mydriatic that even if you give in the night time, over the night, if you are applying it till the morning, it is giving you enough of dilatation. So if they are asking you a question per se and you are giving these values, then it's okay. Otherwise, it is very, very sufficient to use it just night time and 3 days before. In older children, we are using the other ones. There we are not using the ointment, just the drops. Like in children, we are using the 2% homatropine or 1% cyclopentolate, and this is good effective one. And if you talk about the adults, the most common is 1% tropicamide. After 30 to 45 minutes, we are getting. So nowadays, tropicamide is the most commonly used mydriatic and cycloplegic. It is also the standard mydriatic and cycloplegic that we are using in adults, especially for your age people. And what we are using there, we are using the tropicamide along with a combination. So what is that thing that we are using along with the tropicamide? Tropicamide ke saath what we are using is the phenylephrine. The reason why you are interested in using the combination, that they have got same onset as well as duration of action. So onset is about 30 to 40 minutes. So it is very, very, convenient for the students or for the office going people. They can just sit for 30 to 40 minutes, get their pupils dilated, and after 4 to 6 hours the pupils are normal back. Because you know, if the pupils are dilated, it will definitely hamper their normal work. So if I am a student, if I am an office going person, I can just take a leave of one day and I can get my refraction done, and by the evening time I'm back to normal. So that is why it is quite common to use this combination. All right. The cycloplegic effect, which varies greatly in different people and even in the two eyes of the same person, should be tested prior to the retinoscopy by estimating the residual accommodation, which should not exceed by 1 diopter. Now, the cycloplegic effect, they are saying that it is very much variable in different people. So, if I am getting one effect in one person, I will not say, and I cannot take it for granted that I'll get exactly the same effect in the other one. So, that is very, very important. And even in the eyes of the same person. So if one person is getting refraction done in the two eyes, again I can get the difference. So always you should settle for the differences and always see that it should not actually exceed more than 1 diopter. Some amount of difference is normal. Okay. Any mydriatic or cycloplegic should be used with care in adults in whom the angle of anterior chamber is narrow. Now, this is again very, very important. If you remember, I keep on saying this in classes that whenever you do the refraction, no matter how many people are standing outside, no matter how many people the refraction is being done, always check for the angle of anterior chamber, because by chance, if you are doing this refraction in a patient who is hypermetrope, who is having angle of anterior chamber narrow, your one drop is going to occlude the angle of anterior chamber, and this person can land up in the acute congestive glaucoma. So this is very, very important to prevent the emergency. I don't think any person will relish this, and any physician would like this, that the patient have come up for the refraction and has landed up in an emergency condition, the acute congestive glaucoma. So a very simple step, taking the view of the angle of anterior chamber just before the refraction will save the eyes from an emergency condition. So it's very, very important. In older people, the mydriasis should be counteracted by the pilocarpine, and if suspicion of a tendency to angle closure glaucoma exists, and you feel that the dilatation of pupil is necessary, even they are advising gonioscopy and prophylactic laser iridotomy. Now this is a very common thing which occurs with us, because many people who are coming for refraction are also elderly people. I think ophtha is one branch where most of the patients are mostly elderly. So those kind of people are coming to us, and we think that the pupil is somewhat dilated, or angle is narrow, or they have some predisposition towards the angle closure glaucoma. So in those cases, it is always advisable that you have to do gonioscopy, and if you feel like what you call as the need, always do the prophylactic laser iridotomy. So there is one more indication, I will say, of doing the prophylactic laser iridotomy in cases of refraction too. Now coming to important clinical part, what are the difficulties in retinoscopy? Whenever you are doing any procedure, no procedure is actually foolproof. You have some amount of difficulties which are there, especially with the beginners, especially in those people who are also having the cylindrical errors or the astigmatism, because astigmatism is one refractive error where you are having lot of reflexes, and these reflexes will always hamper us in getting the right amount of value. They are always distracting us. So let us see what are the difficulties that we can have in the retinoscopy. First of all, if we talk about the shadows. Now, before going to the irregular astigmatism, let's talk about regular astigmatism only. Even in the regular astigmatism, we have a lot of shadows, and they are not always easy to correct, owing to chiefly the differences in the curvature of different parts of the cornea. Now, you know that astigmatism means the difference in the refractive power in the different meridia. So this difference in the refractive power in the different meridia, it could be due to the cornea also, it could be due to lens also, and very less commonly it could be due to retina. But most common reason is the corneal astigmatism. Now what happens whenever we have corneal astigmatism, you have got difference in the curvature in the different parts of the cornea. There will be a lot of shadows which are going to swirl around, and we are going to be distracted. So usually there is one more thing which has to be paid attention, that the periphery of the cornea is flatter than the center. So what is happening now? The center is having different curvature and the periphery is having different curvature. Now due to this, what is going to happen? The center of the pupillary area will be now corrected by a different lens from the periphery. Now obviously, if the center and the periphery has got a different power, I will have to give a different lens in order to correct it, especially when the pupil is dilated, because when you when you are doing the refraction under the dilated pupil, the periphery is also taking into consideration, and that was one of the reason why we were doing the post cycloplegic test. Now various conflicting shadows may be seen, and a very commonly seen shadow here is the scissors shadow. I think we have already discussed this so many times, that scissors shadow is one thing that you get in cases of regular astigmatism. And why it is called as scissors? Scissors means like this. So here the two kind of reflexes are actually meeting and it looks as if they are crossing. That is why it is called as the scissors shadows, and these can be diminished with the undilated pupil. If you feel like that this person is having lot of astigmatism and we are going to have many reflexes from the periphery, then what you can do, you can do the refraction in the undilated pupil. So at times we can even use the refraction without dilatation, undilatation, if you are seeing lot of shadows. Now we come to the irregular astigmatism. Talking about the irregular astigmatism, the shadow moves in various directions in the different parts of the pupillary area, and therefore an accurate correction cannot be made by spherical and cylindrical lenses. As the word itself says, this is irregular. You are having very varied kind of curvatures in the cornea, that is leading to the irregular kind of astigmatism. So here you are not having just the two shadows which are cutting each other, that is scissors shadow. Rather, you are having many shadows, and these shadows make it difficult to be corrected by the spherical as well as cylindrical lenses. Now we take a specific type of the irregular astigmatism, the conical cornea. By the conical cornea, actually they mean to say the keratoconus. So in the keratoconus, again where we have the irregular astigmatism, you get a typical kind of shadow. This is a triangular shadow. So triangular shadow you are getting in the triangular cornea. It is easy to remember. In the conical cornea, there is keratoconus, their shadow is also triangular. Now in this triangular, what is happening? You are getting the apex at the apex of the cone itself. So this shadow's apex is lying towards the apex of the cornea itself, and therefore it appears to swirl around its apex as the mirror is moved. When you are mirror means they are doing it with the plane mirror. So what they are saying, that when they are actually moving this mirror, what is happening? We were having the conical cornea. So instead of this spherical cornea, we were having this conical cornea, and the shadow that you are having is again conical. So we are having a conical shadow, and the apex of this shadow is towards the apex of this conical cornea. That is why the shadow appears to swirl around. Alright. So in conclusion, now what they are trying to say in conclusion, a word of caution must be added. The correction of the given refraction by the retinoscopy may be easy, it may be difficult. A large number of refractions should have been carefully corrected and considered by subjective test before the beginner should consider himself justified in ordering the spectacles without the supervision. So this is for the beginners. They are saying that there are many things to be learnt in refraction, and procedures are always learned by practically doing it. So though you are being taught every theoretical aspect, but you will see that you learn a lot practically by doing it. So it is a trial and error method in the starting. Slowly and gradually you will come to know that what kind of a shadow is actually suggestive of what kind of astigmatism or what kind of a error, and there are so many difficulties that you actually face while doing the refraction. So one should be actually having the number of subjective tests also done before giving the final prescription without any supervision. Be very careful, because smallest of your act here and there can lead to wrongly framed spectacles and leading to many refractive problems in cases of your patients. And patient satisfaction is the doctor's first preference. That is very important. No matter how good clinician and how good doctor you are, if your patient is not satisfied, obviously you won't be feeling satisfied by yourself. All right. Now the next we come to the automated refraction or the auto refraction. I think most of us has already gone on this computerized eye testing. It's very commonly done in developing countries like ours, and especially it's very common with the students who hardly have time. They do not afford to spend so much of time in getting their pupils dilated and wasting whole of their day. Sometimes when the preparation is going on at a very intensive level and you have got examinations coming along, so it's better that we go for this auto refraction where the refraction without dilatation is done and you are getting nearly good values. So these refractors help in the estimation of refractive error with the help of a machine. Actually this machine is nothing but a computer there, and if you look at the name, these are called as auto refractometers or auto refractors. They are designed to objectively determine the refractive error. Now what you have to remember, the principles on which they are working. So they are working on 3 principles. These 3 principles are the retinoscopic principle that we have discussed up till now. Then we have the Scheiner disk principle, and the third is the grating focus method. So first of all, you should know that it is working on 3 methods or the 3 principles. And what are these 3 principles? We have got a retinoscopic principle, a Scheiner disk principle, and the grating focus method. In the retinoscopic principle, as we already know, there is a retinoscopic reflex which is generated, and you have to see the direction of the movement, which is actually sensed by the light sensors, and you have to see what are the lenses required for the neutralization. Whatever is the lens that is sufficient enough to neutralize that reflex, that will be the power of refractive error. So today we have seen mainly the mydriatics and cycloplegics, why they are required, how they are used, what are their values of onset, their duration of action, and we have also seen that where you should avoid them. Then we have also seen some of the shadows and the difficulties which can be experienced during the refraction. I think this is all for this session. In the next session, we will be discussing the other principles that are used in autorefractometers. If you like the video, please do like the video and share the video with the maximum of the people, those of you think that will benefit from this video, and please do subscribe the channel in order to get the instant updates about any of the videos that are loaded. Thank you and happy ophthalmology.